sometimes, where sometimes we try to get one of our providers there, especially during the busy times, and they just don't get there in time, and that center is forced to call 911, and often there's a delay, and 911 would not have been needed, and sometimes that patient therefore ends up at a hospital where they really don't know the patient. They end up doing a lot more tests and all. So those are the type of cases where if we got them on time to the right place, it would save the 911 visit, and we'll also get to the best place for the patient for continuity of care and for consumption and allocation of resources.
There was an indication that the current ambulance, 911 ambulance service, I guess, has a 7-minute response time.
That's correct.
How is that measured? And who gave you those statistics?
So that's our internal data from our EPCR system, from the time of receiving the call to time on scene.
Okay, so it doesn't count the fire department dispatch time, the 911 time, the fire department time. It's just from when your ambulance was given the call till they got on scene.
I just want to make sure I have a clarification.
That's correct.
That is correct, yes.
All right, so I just want to make sure we're measuring response times the same way. In New York City, we have a local law 119 that measures end-to-end response time. In your statistics, you gave 9.59 as the 9/11 response time. The local law adds about 2 minutes to that to bring it up to 12 minutes overall. So what would your response time for the current St. Luke's Roosevelt ambulance be?
Maybe 9, yeah.
9 minutes.
Thank you. You indicated that you had a 90% availability on St. Luke's ambulance availability. What's the availability on the commercial services that you use?
It's less than that in most cases with our previous vendor. I can't speak for what it will be with our current vendor. We don't have statistics, so we've not put them in service yet. Our contract is...
In your contract with the private ambulances, what standard response time are you demanding?
So we are looking for a similar... I'm sorry, can you further explain your question?
You say that your current commercial providers do not always meet your needs. What needs have you communicated to them that they have to meet, and what penalties have you imposed for not meeting those standards?
I'm going to pass this to Dr. Ramsey because of the penalties of the contract. I concur.
Yeah, so first of all, at this moment, we are not, we have just become contracted with a new entity for our 911 services. So we haven't even started to have them, to watch their performance. The contract with us does involve quality measures, response time being one of them, and there are some incentives for them and for us to meet 90% and above.
And are they meeting it?
They haven't started yet.
The TransCare,
TransCare did not meet that
and that was in the contract.
by a number of percentage points.
Okay. All right. Dr. Mungel talked about community paramedicine and EMS involvement. Do you need an ambulance to provide community medicine?
Thank you for the question. To provide some clarity, a community paramedicine program we provide is a urgent response capability in an ambulance in which they use telemedicine to coordinate that care with a physician. We are operating under all New York City REMAC protocols and using medical direction that's certified through the REMAC. In that model, it is expected that the unit responding has transport capability, so yes.
Can you use a model without transport capability. I believe there was a story in last week about Houston Fire Department using Ford Escapes for paramedics or EMTs to respond.
I think there are, as there's one thing that's going on in New York City is the fire department, I believe, is doing a pilot with fly cars. I am not overly familiar with any other use of fly cars in the city. It's not something that I have a lot of particular expertise in. I would say that in the community paramedicine world, I would just hesitate to compare because I think sometimes that label gets used with some programs that are a little bit different, in which they might be doing scheduled home visits and things like that. So I don't know the particulars of that particular model, but it's possible to use medics in a fly car in some places, and I haven't explored all the regulations around that in the city.
But for your model of community paramedicine, how do you envision the ambulance being requested and dispatched to a patient?
So this is at the physician request, so it's not direct to the public. So a patient does not have the ability to request community paramedic through this pilot program. In this model, we had a group of primary care physicians who do an exceptional job of having wraparound services for their patients. So unlike most practices where people may not attempt to call a primary doctor, in this practice, a large percentage do. As a caveat, that's only 50%, and that's much larger than other practices. Still, that physician has one option of trying to manage it over the phone, which sometimes they could do successfully. They have the option of triggering a 911 call. They have the option of asking for a transport, and now they have an option of getting a eyes and ears on the scene and actually trying to make interventions to stabilize the patient in the home. So we think it's a significant, it's a really great use of paramedicine. We think this uses paramedics to their full potential. So we think that this is a successful model that should be expanded. I know Northwell has a similar program, and I know they are expanding it as well. So I do think that this is an increased utilization of EMS to serve population health needs, and I think that's a key element that we feel is relevant to this conversation in terms of the increased increased burden on EMS.
Does a patient have an opportunity to call 911 themselves, or are they forbidden to?
Patients always have that opportunity to call 911 themselves, and the physician has the opportunity to call 911. And so, yeah, I think in this model, it's the physician has had the opportunity to get a sense of what's going on. The patient has a level of trust with that physician because it's their own doctor, and therefore, when the physician tells the patient, I'm going to dispatch an ambulance that has the exact same capability of the 911 unit, but they give them an estimate of ETA, it's within 60 minutes or something like that, usually around 35 minutes. When they give that patient that ETA, usually in our model, we haven't had an episode where the patient felt that wasn't acceptable and would call 911, but it is a concern.
So community medicine response time, 30 minutes is acceptable for an ambulance.
We're just exploring this model. It's a pilot program, so I hesitate to sort of make that claim, but that's what we experienced in our pilot. Brian?
I actually do. I'm sorry, I didn't mean to interrupt you, Jeff.
Go.
I'm intrigued by this community paramedicine, and I'm also a visual learner. Can you give me a situation, because I'm trying to get, I teach algebra and I can deal with the abstract. I'm having a hard time dealing with the abstract and what community paramedicine is like. Can you give me a scenario where it would happen? Because I'm just not getting my mind around it.
Sure. So the specific model that we're describing is a patient who has an acute complaint. So,
Such as
shortness of breath. This is a patient who's well known to their physician, and they have a good relationship with their physician in this practice. Every patient has the opportunity to triage themselves, and we all, I think, bemoan the fact that patients end up in the emergency room without having tried to call their physician for chronic conditions that maybe in retrospect people feel are not an emergency. For a patient with chronic CHF, for example, congestive heart failure, perhaps they do get short of breath from time to time. Perhaps the physician has instructed them in advance that there's some method by which they can manage that symptom before they end up in the emergency room getting perhaps uncoordinated care, or perhaps getting admitted. And as we've described, the health system has now been asked to take a much larger level of responsibility for the care of that patient. So this patient with congestive heart failure that now has a little bit of shortness of breath, they're rightfully nervous about their symptoms, despite all the education that hopefully they've received through our preventative efforts. They may feel a need to call and reach out to a clinical care provider. Many patients, if you work in an emergency room or have been in an emergency room, you might know that a patient might have said, I tried calling my doctor, but they couldn't do anything for me. They said, go to the ER. This is different. Now they can do a couple of things. In addition to doing their best to get a sense of how you're doing over the phone, they can actually get somebody to the scene who's a trusted, qualified healthcare professional, able to give them vital signs, an EKG.
Dr. Freeze, 1 second. So he's got shortness of breath, or she's got shortness of breath. The doctor in Mount Sinai says, hold it, I'm gonna get an ambulance to you in half an hour. What is it? What's the interaction? What happens?
Sure. Sure. So the patient calls the physician. They say, I have shortness of breath. The physician asks them questions. The physician doesn't follow any particular protocol. They are a physician. They have a lot of independence. They manage their patient as they wish. They might have other tools at their disposal to try to alleviate that patient's concerns. They might tell the patient to come to them in the office the next day. So they have a variety of options. If they chose to dispatch this resource, they would tell the patient, I'm a little concerned about your condition. I'm not sure right now how sick you are. Rather than automatically send you to the hospital, let me send a special unit that's been has some minor additional training and has telemedicine capabilities, and with whom I have a relationship, so that I can actually give them orders. I will dispatch that unit. They'll have to obtain ETA, make sure the patient's okay with that ETA, dispatch the unit. The unit arrives on scene. They do an assessment, and they contact that physician as they would medical control.
Okay. So is there medical control over that MD who says, you know what, I think I want to get a bus over to Mr. So-and-so?
By medical control, can you?
Well, I'm going to say, all right, so Dr. Smith says, I'm a little bit worried about my patient and thinks, you know what, I know that there's mobility issues. I'm going to go send somebody over to meet the patient. By somebody, I mean you direct, Dr. So-and-so directs an ambulance in this paramedicine program to go and check on the welfare and see what's going on. How does that happen, and how do we know that there aren't 10 different doctors in your large system that aren't doing the same thing at the same time, taking up all of your resources?
I'm going to rephrase the question to make sure I understand.
Sure.
You're asking how do we make sure as a health system that we're not overutilizing this resource?
That's one piece. And is there some sort of a coordination of this sort of a program, or is it once you enable a doctor in this pilot program, you give them license to go and direct resources as they professionally feel fit?
So you're asking
several questions involved in the whole thing.
Yeah. So first of all, only I am the REMAC certified physician. I'm a member of the REMAC. I am the one who conducts the classes that trains the. I'm the physician that trains the other gives the course and oversees the entire credentialing process. We submit those to the REMAC. So there's a limited number of physicians that currently have that availability. When we had the pilot up and running through TransCare, the physician has at their own discretion the ability to dispatch the resource. However, there's an immediate electronic alert that goes to myself as well as to administrative staff over the program. There's 100% QA of that program. The physician documents in the medical record. The crew documents their normal patient care record. All of those records are fully reviewed and received by myself and our team. And so there is, I know that there's only those 36 responses. There were no other responses. We think we were very successful in both effectively monitoring the program. I think rather the program was underutilized rather than overutilized. I think that in the absence of the program, there's been numerous patients within this patient population that were clearly would have been amenable to the service. It's also a safety valve for our hospital home program, which has been missing, and we've heard we know at least 3 patients that had to come to the, well, I don't say 2 patients that had to come to the emergency department for further evaluation within our hospital home program. So I think that if I understand your question correctly, there is very good oversight and regulation of the program, very good quality assurance over the program, and that would continue.
Okay. All right. Thank you. I'm sorry for interrupting the call.
Okay.
Denny?
No, continue.
I apologize for interrupting.
All right, talked about 11 ambulances for the expansion. They're all ALS?
No. Do you want to comment
In
further?
In the budget plan, it talks about 11 ambulances, 11 stat packs ALS, 11 life pack 15s.
And Ms. Denny, if you could just, so
Right, so I mean, again,
everyone is aware,
I'm
where
numbered
this
page.
a number page in attachment or in the main application.
We're familiar with it.
So I think I understand your question.
Can
and
you
you're-
direct me
you're-
where I'd love to be catching up with you. Where are we? In the main application, before project narrative, post project narrative?
he's-
Yeah, just like to know where it's at. Give my
he-
comment.
You're asking, can you tell me where you're, which?
There was a printout from online, I don't have it. There was no page number.
We can certainly respond to it.
Attachment 11.
11, thank you.
Mount Sinai West EMS expansion capital budget.
I'm
Thank
just
you.
waiting for everybody to get to the appropriate place. So the simple answer is we equip all the ambulances similarly so that they can be used throughout the system as either an ALS or a BLS ambulance as needed.
But do you intend to use them all as ALS or some as BLS?
We intend to use them as both ALS and BLS.
All right, the 11. You presently have senior care EMS covering Beth Israel. There's 4 units out of that.
Those are, they're not in place, those are 4 additional units.
So the 11 that you're planning to buy and put in new service, they would not replace the 4 units that senior care is supplying to Beth Israel.
That is correct. They would not replace the 4 units that senior care is using for Beth Israel.
You seem unsure of that.
No, I'm certain, I am very certain that senior care will be contracted to provide 4 ambulances for Beth Israel, 1 ALS, 4 BLS ambulances, and they will have the appropriate recall ambulances that are required for the fire department contract.
Let me just further comment. So I think a lot of what you've heard tonight, many things, but I want to make sure you understand we're not willing to experience the tremendous vulnerability that we experienced in late January and February. So these ambulances, so we want to make sure that if a similar situation happens where a vendor suddenly can't provide for our patients, we don't ever want to be in that spot again, that we can immediately fill in behind. And that. I really hope you understand that that's a theme here so it's not only about, so we always are going to need to diversify with many vendors. Again, that whole comment that we've made multiple times in this, how we still are going to be very much involved with vendors across our system, but we do not want to be in a situation like we were in just a few months ago.
So 11, you're going to use some as spares for the current 17, 4.
Yeah, sure.
So that would give maybe 7 to cover the rest of New York City outside the Midtown area.
So I just want to clarify
Are
when,
those 7 going to be staffed 24/7, 365?
so we are still in this evaluation phase of understanding the additional need that is required to make sure that we are doing the additional services in the interfacility side, the additional services that are needed for the Paramedic Plus program and the hospital at home program that you heard about. So we anticipate we will staff all of those ambulances that are not beyond the ones that are required to be spares to provide service to the health system. But I just wanted to follow up on something that Dr. Ramsey said about not being in this position. We were in the unfortunate place where we have actually experienced this not once, but twice with a previous ambulance provider. I know there was a comment at the previous hearing asking if other ambulance services had left the region unexpectedly. They used the word bankruptcy. I'm just saying use the word leaving the system unexpectedly, because I don't know why they left, but they left without notice one day. So in 2001, we lost regional ambulance service that serviced Mount Sinai, and it was a much more violent disruption than the disruption that we had with TransCare. So we've had this experience with not one, but 2 commercial ambulance providers.
You talked about financial stability. In the consolidated statements of operations for St. Luke's Roosevelt Hospital Center and affiliates, I'm not a financial expert, but I'm looking at operating revenues and operating expenses for 2014 and 2015. In both years, the expenses exceeded income.
Are you talking about for the institution?
I'm talking about the consolidated statement of operations for St. Luke's
Right.
Roosevelt Hospital Center and affiliates,
This is
which
the
holds the CON.
Right.
Financials.
That's page
Right.
4 under the financial statement.
Right. So,
Spending more than you receive is not good.
well, if you remember, 3 months before 2014 is a financially completely depleted continuum, including those 2 hospitals. We're in a situation that we had to take over, and we're still in the middle of crawling out of that hole. But as a system, we are very much still very healthy in terms, you may have even read in Cranes in the last just week how much we have improved our finances. And so the health system in general can sustain that kind of an early loss. And as we go ahead and become operationally more efficient and clinically more expert in what we do, we're developing centers of excellence at both Mount Sinai West, previously Roosevelt, and Mount Sinai St. Luke's, previously St. Luke's. We expect this year to be much improved. And again, I want to emphasize that that's what hospital systems that have plenty of finances behind them, even though they are a nonprofit institution, are able to sustain while they bring excellence to the communities that they serve.
All right, but you're still out losing money operating.
Actually, Mount Sinai
That-
West
that
is
division-
now,
I would say that division of the corporation is,
right.
This
that-
division of the
Yeah,
corporation,
right.
which holds the operating certificate for the ambulance.
Yes, at this time.
Okay. We're reading in the
We,
newspapers
by the way,
that
can
one
I
of the
just make one more?
Yeah.
We will be moving towards a full asset merger very, very soon.
We've been reading in the newspapers that one of your major hospitals in Lower Manhattan will be downsizing and moving to another location. Will that location be inside or outside your current operating area?
It will be very close to current Beth Israel, and it will stay outside our operating area unless this CON is approved. And we have full plans to run a very efficient but very busy emergency department. There will be no disruption of care, and the ambulance CSLs, all that we are honoring for forever.
And the additional ambulances that you're going to be having available, where will they be turning out from? Where will they be stationed during the day?
Well, first of all, we won't change at all current operations about where, first of all, they're CSLs, and then turning out they will be, coming back to Mount Sinai Beth Israel or a near location. But that's our plans. As usual, EMS is very important to us, and so we will make sure that they have the proper facilities to be able to turn that around.
All right. The Beth Israel is covered by senior care. I'm talking about 11 ambulances that you plan to use. Where would they be turning out from? Where would they be stationed during the day, since you're requesting 5 boroughs?
Do you want to answer that?
So they'll turn out from Mount Sinai, St. Luke's, and Mount Sinai West, but they will be deployed to locations based on our need, talking with our transfer service.
Your need.
Based on the patient's needs that we encounter, which are being monitored by people like Dr. Walshaw, and Dr. Munjal, and any of the other system needs that are going on throughout the city. So if we see that there's a slow response time to our needs in the community, and we have patients that need to be moved, we will deploy them to that community. So to not overburden the system that might not be responding as expected at that time.
All right. In Richmond County, Staten Island, primary care ambulance has 18 ambulances. Priority 1 ambulance has 29. Richmond County Ambulance Service has 40. They may well not be on Staten Island. Richmond Medical Center has 11. Staten Island University has 13. And there's 2 volunteer squads. What, if you were to expand to Staten Island, what are you going to provide them that is not being provided at the current time?
Well, right now, we're transferring some very sick patients from Richmond University Medical Center. We're closely aligned with their cath lab. Sometimes we're able to get good ETAs, and sometimes we are not for those cases, whether it's ALS transports. The cath lab sometimes even has sicker patients on balloon pumps. So sometimes we do have delayed ETAs from our affiliates. In addition, we work closely with a practice there, the Victory practice, and there'll be population health needs. And again, some of those might be the internal needs as we work with that practice on managing the health within the population outside the hospitals. But we're growing our primary care footprint in that area as well. So again, we might be using these ambulances, and transfer service might be saying, hey, we have all these population health related transports to do, and that's going to free up some of the vendors that you mentioned to do some of the more acute transports. It's just really going to depend on the need.
So
Well,
you
we
would
see that need now.
send an ambulance from St. Roosevelt to Staten Island to pick up